Okay, so moving to the next topic, subacute thyroiditis, what's called Duchenne thyroiditis, is thought to occur following viral infection and typical presence with hyperthyroidism. So it falls under hyperthyroidism. You have to remember that. And the features are hyperthyroidism, painful goiter, raised DSR, and globally decreased uptake on iodine 131 scan. Um, what you find is tender goiter, hyperthyroidism, and raised ESR. Globally reduced uptake on technetium thyroid scan is typically de-Quervain. So globally reduced uptake on technetium scan, you have to know that. And some of the things which you can relate and remember together. Management is usually self-limiting. Most patients do not require treatment, and thyroid pain may respond to aspirin or other NSAIDs. In most more severe cases, steroids are used, particularly if hyperthyroidism develops. Graves' disease, one of the most important ones. Features are specific to Graves only in Graves. Eyes, these are like specific features for Graves' disease. Eyes, exophthalmos, ophthalmoplegia, then pretibial mixed edema, thyroid acropathy, skin. You will see low TSH, like 0.5 to 5.5. This is the normal one actually. Elevated total T4, 90-22 is normal. TSH receptor antibodies are TRAP positive, have up to 98% specificity and sensitivity and 99% specificity for Graves. Confirms diagnosis and can distinguish between Graves' disease and other causes of hyperthyroidism such as toxic adenoma and toxic multinodular goiter, which has diffuse uptake in scan. And autoantibodies, which you'll find in Graves' disease, anti-TSH receptor antibodies, stimulating antibody 20%, and anti-thyroid peroxidase antibody 50%. Managed as thyrotoxicosis. Okay, next is subclinical hyperthyroidism. In this subclinical, so it's T3 T4 are normal, but TSH is low. Causes can be elderly female with multinodular goiter or excessive thyroxine may give a similar picture. Complications can be atrial fibrillation, SVT, bone metabolism, osteoporosis, increase the likelihood of dementia. And management committee TSH levels often revert back to normal. Therefore, levels must be persistently low to warrant intervention. Okay. A reasonable treatment option is a therapeutic trial of low anti-dose anti-thyroid agent for approximately 6 months in an effort to induce a remission. So TSH usually goes back to normal. Therefore, levels must be persistently low to do something about it. Okay, some informations like anti-TSH receptor stimulating autoantibody, often referred to as thyroid stimulating immunoglobulin, are almost diagnostic of Graves' disease, the most common cause of thyrotoxicosis in the UK. And radioiodine therapy can precipitate thyroid eye disease, but a majority of patients will eventually require thyroxine replacement due to hypothyroidism. So, ultimately, when you do give radioiodine therapy, uh, patient goes towards hypothyroidism, and you need iodine thyroxine replacement as well. In toxic multinodular goiter, it's a thyroid gland that contains a number of autonomously functioning thyroid nodules that secrete excess thyroid hormones. Nuclear scintigraphy reveals patchy uptake. The treatment of choice is radioiodine therapy. Okay. Next is toxic adenoma, Plummer's disease. Toxic adenoma management is radioiodine, subtotal thyroidectomy. Subtotal thyroidectomy in pregnancy, medical management, but if failed, subtotal thyroidectomy. That's what you do. Okay, hypothyroidism in European countries, primary atrophic hypothyroidism is the most common cause of hypothyroidism. Atrophic hypothyroidism is the most common one. And whereas in North America, Hashimoto's thyroiditis appears to account for the majority of the cases. Causes can be causes affects around 1-2% of the female in the UK and is around 5 to 10 times more common in males than females. Primary hypothyroidism, primary atrophic hypothyroidism, most common cause in Europe. Autoimmune disease associated with IDDM, Addison's or pernicious anemia, 5 times more common in women. Hashimoto's thyroiditis, autoimmune disease above with goiter. So primary hyperthyroidism can have these specific things that can come to your mind. These differentials are there. Primary atrophic hypothyroidism, Hashimoto's thyroiditis after thyroidectomy, drug therapy, dietary iron deficiency. Well, for drugs, it will be lithium, amidon, or antithyrotoxis carbimazole. After thyroidectomy, of course, you will have hypothyroidism. And Hashimoto's, you will see autoimmune diseases above with goiter. Hashimoto's will have goiter and anti-TPO. May cause transient thyrotoxicity in the acute phase, 10 times more common in women. And 5 times more common in women is atrophic hypothyroidism. Secondary hypothyroidism may be caused from pituitary failure. Other serious symptoms like Down syndrome, Turner syndrome, celiac disease can also cause. For management of hypothyroidism, firstly we have to start levothyroxine, of course. Initial starting dose of levothyroxine should be lower in elderly patients and those with ischemic heart disease. So for ischemic heart disease, thyroxine dose should be lower, like 25 to 50 microgram per day. Following a change in thyroxine dose, thyroid function test should be checked after 6 to 8 weeks again. And the therapeutic goal is normalization of the thyroid stimulating hormone levels, as the majority unaffected people have a TSH value 0.5 to 2.5. It's now thought preferable to aim for a TSH in this range. So TSH value is 0.5 to 2.5. Okay, dosage changes should of course also take account of symptoms. There is no evidence to support combination therapy with levothyroxine and liothyronine. Side effects of thyroxine therapy: hyperthyroidism due to overtreatment, decreased bone mineral density, and worsening of angina AF. So this can happen due to thyrox AF, BMD, angina, hyperthyroidism. So therapeutic goal is normalization of the thyroid stimulating hormone levels. So preferred level is 0.5 to 2.5. Okay. Hashimoto's thyroid is another very important topic. It's also part of hypothyroidism. It's an autoimmune disorder of the thyroid gland. It's typically associated with hypothyroidism, although there may be a transient thyrotoxicosis in the acute phase. We've talked about it earlier. It's 10 times more common in women. And features of hypothyroidism: goiter, firm and non-tender. Tender is in subacute and positive microsomal antibodies, anti-TPO, there is anti-thyroid peroxidase, and anti-TG antibodies are positive. So very much diagnostic anti-TPO. So subclinical hypothyroidism: normal TSH and increased TSH. So normal T3 T4, increased TSH. No obvious symptoms. Risk of progressing to overt hypothyroidism per year. Increased risk by presence of thyroid antibodies. So the antibodies are very important. You have to remember the antibodies, like which one is for what. Okay, so treat subclinical hypothyroidism if TSH is more than 10. That's when you start treating hypothyroidism. And thyroid autoantibody positive or other autoimmune disorder or previous Graves' disease history. Okay, Pendred syndrome, that's an autosomal recessive disorder of defective iron uptake. Features are sensory neural deafness, goiter, euthyroid or mild hypothyroidism. Thyroid function is usually straightforward. Thyrotoxicity, like thyrotoxicosis, is decreased TSH and increased FT4. In T3 thyrotoxicosis, T4 will be normal. And then primary hypothyroidism, increased TSH and decreased FT4. Secondary hypothyroidism, decreased TSH and decreased FT4, both low. So secondary hypothyroidism will be see that both of them are low. Interpretation: steroid therapy is required prior to thyroxine. So give steroid first if you find both of them are low. CQ thyroid syndrome is something common in hospital patients. So like both are low as well. So all of a sudden, in a very complicated patient. Poor compliance with thyroxine, TSH is more, FT4 normal or more. Steroid therapy, TSH goes down, FT4 is normal. Steroid can suppress TSH as well. Okay, CQ thyroid syndrome, now referred to as non-thyroidal illness. It's often said that everything TSH, thyroxine, T3 is low. In some cases, the TSH may be normal. Changes are reversible upon recovery from the systemic illness, usually in hospitalized patients. So what are the skin manifestations in thyroid disease? You have to remember as well. For hyperthyroidism, it's pretibial mixed edema, like erythematous lesions above the lateral malleoli, and thyroid acropathy clubbing. It's like bony formations and in the fingers as well. Scalp hair thinning, hyperthyroidism as well, and there's increased sweating. And hypothyroidism is dry, cold, yellowish skin, uh, non-pitting edema, hands and face, dry, coarse scalp hair, loss of lateral eyebrows, eczema, and xanthomata. Pruritus can happen in both hyper and hypothyroidism. So, for the purpose of postgraduate exams, pretibial mixed edema is associated with thyrotoxicosis. There are, however, case reports of it being found in hypothyroid, especially the diffuse non-pitting variety. Okay, pregnancy problems in thyroid. Okay, in pregnancy, there is increase in the level of thyroxine binding globulin. This causes increase in the level of total thyroxine, but does not affect the free thyroxine level. So increase in the TBG globulin, but this causes increase in the total levels of total thyroxine, but it does not affect free thyroxine level. Okay, so FT4 is not increased, but total thyroxine is increased. Thyrotoxicosis. Untreated thyrotoxicosis increases the risk of fetal loss, maternal heart failure, and premature labor. Graves' disease is the most common cause of thyrotoxicosis in pregnancy. Okay, it's the most important one. It's also recognized that activation of the TSH receptor by HCG may also occur, oftentimes transient with gestational hypothyroidism. HCG levels may fall in second and third trimester. So it's recognized that the activation of the TSH receptor by HCG may also occur, oftentimes transient gestational hypothyroidism. HCG levels will fall in the second and third trimester. So, what's the management for pregnancy? Propylthiouracil is the antithyroid drug of choice. Very important. Not carbimazole. It's used by some endocrinologists. Rarely associated with aplasia cutis of the neonate. Maternal free thyroxine levels should be kept in the upper third of the normal range. To avoid fetal hypothyroidism. Thyrotrophin receptor stimulating antibodies should be checked at 30 to 36 gestation, helps to determine risk of neonatal thyroid problems. Block and replacement should not be used in pregnancy. Radiotherapy is of course contraindicated. So what do you get? Propylthiouracil. Propylthiouracil has the advantage of being excreted to a lesser extent than carbimazole in breast milk. Well, there is, I think, a newer guideline for the trimester, which trimester what you use. So you have to check on that. Hypothyroidism, thyroxine is safe during pregnancy and breastfeeding. Serum thyroid stimulating hormone measured in each trimester and 6 to 8 weeks postpartum. Some women require an increased dose of thyroxine during pregnancy. Thyroid cancer, very important as well. So features of hyperthyroidism or hypothyroidism are not commonly seen in patients with thyroid malignancies, as they rarely secrete thyroid hormones. So we don't really see that. The types are papillary, the most common one, 70%. It's often in young females and with excellent prognosis, associated with FAP. Follicular is 20%, spread through blood vessels. Spread through blood vessels, and medullary is 5%. Cancer of parafollicular cells secrete calcitonin, part of men too. So medullary type is also not very common, but 5%. Cancer of parafollicular cells. So let's go back to what we said. So it's often excellent prognosis, and young female are more often affected. Follicular one is spreading through blood vessels. Medullary is like cancer of parafollicular cells secrete calcitonin, part of men too. Okay, anaplastic, not responsive to treatment, very important. Can cause pressure symptoms. These things are coming in the exams. All these informations. Lymphoma associated with Hashimoto's and other autoimmune disorder is rare. Management of papillary and follicular cancer, these two. Total thyroidectomy is recommended, followed by radioiodine I-131 to kill residual cells. Yearly thyroglobulin levels to detect early recurrent disease only after thyroid ablation. Coming towards the next topic is primary hyperparathyroidism. Is very important. in prostate exam primary is typically seen in elderly females with an unquenchable thirst and an inappropriate normal or raised parathyroid hormone level. It's most commonly due to solitary adenoma. Seen few cases about this. Okay, the PTH level. Mm, the PTH level in primary hyperparathyroidism may be normal. What are the symptoms you see here? Bone stones, abdominal groans, and sagging bones. So polydipsia, polyuria, peptic ulceration, bone pain, fracture, renal stone, depression, hypertension. Causes is solitary adenoma, hyperplasia, multiple adenoma, carcinoma. Associations are hypertension, MENT 1 and 2. Investigation can be low phosphate and high calcium. PTH may be raised or normal. Technetium maybe subtraction scan can be done. That we did a few days back. IV fluid, parathyroidectomy, bisphosphonate. That's what can be done. And hypoparathyroidism. Well, it's primary hyperthyroidism, PTH secretion is low. Secondary to thyroid surgery can also occur. You'll see decreased calcium and increased phosphate, opposite to hyperparathyroidism. And the features can be CNS seizures, Parkinsonism, dystonia, calcification, heart, decreased calcium associated cardiomyopathy, laryngospasm, nephrocalcinosis, renal stones as well, paresthesia, anxiety, cataract, all these things can happen. Target cells, pseudohypoparathyroidism is target cell being insensitive to PTH. So PTH is there, but target cells are insensitive. In type 1 pseudohypothyroidism, there is a complete receptor defect, whereas in type 2, the cell receptor is intact. So type 1 receptor defect. Type 2, the cell receptor is intact. Due to abnormality in G protein, autosomal dominant fashion, associated with low IQ, short stature, short 4th and 5th metacarpals, and low calcium, high phosphate, high PTH. So if you remember all that, is it high PTH? I think it's low PTH. Diagnosis is made by measuring urinary CAMP and phosphate levels and following an infusion of PTH. In hyperparathyroidism, this will cause an increase in both CAMP and phosphate levels. So PTH secretion. In pseudohypothyroidism type 1, neither CAMP nor phosphate level are increasing, while in pseudohypothyroidism 2, only CAMP rises. So yeah. In pseudohypothyroidism, similar phenotype to pseudo, but normal biochemistry. Okay, diabetes mellitus, very important topic as well, and it's pretty vast, a lot of information, but I think you know all of it for your basic medical degree. You already have idea about everything.